Okay, hello everybody. I'm Brian, and we're here at AAMI neXus Day 2, 2026. And I'm here with longtime AAMI friend and director of the Archimedes Center, Kevin Fu. You're also a professor over at Northeastern University, focused on cybersecurity. Is that right, Kevin?
That's right, the intersection of cybersecurity and healthcare delivery and medical device design.
Yeah, and this is the conference to be at for those kinds of
It's the
discussions.
place. Amy is the place.
I love to hear it. You were just part of a really exciting panel this morning, and so I wanted to pull you in and talk a little bit about that panel. It, I hesitate to say it because it wasn't a negative thing, but that was a very off the rails panel. A lot of wild discussion going between everybody. We had Seth Carmody from MedCrypt, you from Archimedes, Stephen Gilbert from, I guess we make it simple because I don't want to murder it here, but it's the EKAF Center for Digital Health, and Matt Hazet from MedSec, and Justin Post from OST. Uh, Pretty stacked cast. And what was interesting about that was that there was a lot of very different perspectives and opinions. So we got into something of a debate throughout the whole of that. What were your primary highlights from that panel?
Well, my primary highlight is just how we're still failing at the really easy security problems, and yet we're facing the harder ones. And so, one of the anecdotes was, look, we're getting into discussion of all the nuance of sort of security, reverse engineering, and hacking. And yes, those are real things, but at the end of the day, some medical device manufacturers still just set the default password to password. It doesn't take a rocket scientist to figure out what's wrong with that one. So we're still defending against these sort of baked in, horribly insecure practices, but at the same time, we have these extremely advanced adversaries, sometimes with nation state level backing,
Yeah.
that we have to defend against. So it's hard. It's hard.
It shocks me that to this day, weekly, Amy is rightfully giving us training on phishing, and hey, this is a simulated phishing attempt. Glad you caught it, and it feels silly to me, I guess, as a digital native generation, but this even that's still considered a basic cybersecurity threat that we're all dealing with. Is that right?
Yeah, phishing is still a problem, and with AI and LLMs, they make it much more convincing to do
Mm.
phishing. So, but in my opinion, anytime we have security training, that's really, in my view, a failure of the system. If you're having to train someone, that tells me you didn't design it right in the first place. So that's my opinion on security
Okay.
training.
So your opinion is valuable, and I do want to then transition into then from the discussion, and everybody's throwing around their different ideas, and you're saying, hey, we need to focus specifically on just get the fundamentals down. How do we go ahead and do that then, right? So there's a failure in the system. What are the steps that we should be taking?
Well, I think it's really it's always been back to basics, but it's still back to basics. Simple things like, if you're doing medical device safety, you wouldn't skip hazard analysis, right? That's sort of one of the early steps. So with computer security, you wouldn't skip something called threat modeling.
Mm.
Threat modeling is sort of a 101 tabletop practice where you enumerate the different ways that things can go wrong, and trying to understand what the adversary might do to cause your system to malfunction in ways you did not expect. And that's really the starting point to design a securable system. To have, and FDA uses the term cyber secure device. Um, uh, if you skip over this step, you're kind of doomed from the rest. If you do the threat modeling, it doesn't mean you're done, but it means you have hope.
Yeah. That's and it's interesting too because Pat Baird he's the co-chair of the AMA AI group, and he's also was moderating this panel. I think he was the one who mentioned that, and actually you brought this up too, that the adversaries, the bad actors, are so much far ahead because they have less to worry about in terms of how they're approaching their attack. They can pursue new, different avenues of attack, while the health systems on the defense are still approaching, I guess, the same areas of vulnerability. Is that right?
Yeah, I think the adversaries are very ROI market driven,
Hmm.
and the defenders are very compliance driven. So of course they're going to be easier to trick and defeat because they're behaving based on sort of nonsensical documents. But
So
with
then how do you wind up anticipating what the adversaries are going to do if they're constantly changing their approach?
So I don't think there is a good way to anticipate what the adversary is going to do a year or two later. Uh, Sometimes I talk about what's ransomware 3.0 going to look like. We don't really know. Um, and this is why threat modeling, although it's so simple, it's sort of akin to show your math on a middle school like math assignment. Um, uh, by doing threat modeling, it tends to lead to systems that are more agile. And when I say agile, I mean you can adapt it. So if the threat model changes a year from now, you have a plan B. Basically, you have a way to address the shifting threat landscape. So hey, maybe today you're defending against like you said phishing attacks, but maybe tomorrow it's going to be some AI-driven automated LLM breaking into your system. Um, you might not be able to solve that problem today, but by building it into your threat model, you leave the ability to later issue, say, a patch
Mhm.
to bring your medical device up to a different kind of threat model.
Now, we are going to talk about patching and modeling, so I'm
Okay.
glad you brought that up. But before we do that, I wanted to ask, by the end of this, the panel that you were part of, we were getting a lot of really interesting questions. I was curious if any of them jumped out at you as, oh, that's something that we should be discussing.
Well, um, I think a big question is always just how to grok this cybersecurity thing. And so there was one audience member who was coming from more of a biological background and was explaining it in terms of infectious diseases. And
Sure.
I think it's really important for technologists to realize security is not the end game. The end game is better patient outcomes.
Mm.
And so it can be really tempting for a security expert to come in and have some magic pixie dust solution, or even one that actually works, but it might not matter because if you have a perfectly secure system that doesn't lead to better healthcare outcomes for patients, what's the point? I think keeping it real, keeping it patient forward is going to be really important. That was my takeaway from some of the questions at the end of the panel.
No, that's fair. I can imagine that a hospital system that is completely off network would obviously be very secure, but suddenly we don't have all the patient information we need to give care. So there is that. I mean, that's a very extreme example, but I'm
Mm-hmm.
sure that's the where how you toe the line
Mm-hmm.
between security and efficacy.
Right. And so it's always
Yeah.
going to boil down to risk management. And you'll find inflection points where you look at it and you go, well, that's a risk we shouldn't be taking. But sometimes you have to take calculated risks. And that's what the practice of medicine is all about, balancing risk benefit trade-offs.
Yeah.
And so looking for those sort of wins for the risk management.
But that actually does then go back to if we had a way in which we could assess how a system, at least in general terms, would respond to one attack or another attack, like you were talking about before, that would give us a idea of how to respond in the future when the attack actually happens. That leads me to the project that is currently going on at the Archimedes Center. I know that Archimedes just received $19 million for a whole hospital simulation and vulnerability management platform project. Uh, we're calling it the Patch of Asclepius, which I'm probably absolutely slaughtering the name of a Greek god of medicine and healing. So sorry, Asclepius. But I'm curious, what is that all about? Can you explain it to me?
Well, it's all Greek to me too. Uh, so Let me explain from the public literature on this. ARPA-H has publicly announced they have this program called Upgrade. It's on the ballpark of a $50 million portfolio. And so our center is funded up to 19 million to do this whole hospital simulation as well as a vulnerability mitigation platform. What does that mean? Um, it's trying to address a gap that I've been discussing actually for exactly 10 years now, because 10 years ago, we were in Congress, a number of us,
Mhm.
after something called the Dyn attack. The entire internet went down for a day because of some warring Minecrafters, but that's another story. But at this hearing, I argued to the congressional leaders, hey, we really need to stand up a national capability for some kind of akin to crash safety testing for hospitals and medical devices. This sort of one by one, component by component, this infusion pump, that pacemaker. It's good to do, of course, to do security assurance cases of that nature, but what about the whole system, an entire healthcare delivery organization? And so I argued we need to stand up a $2 billion center, like imagine brick and mortar, a real hospital with no patients, so that you could do these kinds of tests, like what happens if this goes on, but you don't want to harm patients. And so the program we're working on under the upgrade program is slightly different, but you can find more about it on our website at securemedicine.org. But again, whole hospital simulation and a vulnerability mitigation platform, and it's all about being able to combine elements of clinical workflow with a cyber range. And so understanding how long it'll take to patch some kind of security vulnerability in the healthcare delivery environment,
Mhm.
and then understanding what leads to that and what can we do about it. And ultimately, my hope is that it'll lead to better patient outcomes.
No, it does make sense. And it's something that you had mentioned to me offline before we started recording here was that the simulations that your team might be able to create using this system include even the human element. So, like you said, you could simulate the clinical environment, how doctors might respond to things, or if human engineering is going on, anything of that nature. Can you tell me a little bit more about that? How does that work?
Sure. So the dream is, of course, to get whole hospital simulation that gets as close as possible to the real world. And
Yeah.
there's that famous phrase, all models are wrong, but some are useful. This falls into that similar camp. But one way to make things where we have not yet hit a point of diminishing returns is having a notion of representing human behavior in hospitals and healthcare delivery. And when I say an agent, for instance, to represent human behavior, I want to represent, let's say, a clinician who doesn't want to follow the rules of the hospital, or maybe I'm going to represent a patient who plugs in a device into a random USB port. These are just examples outside of the program, um, but by having agents that can represent these different common roles,
Yeah.
you can begin to understand when a patch needs to be deployed into a healthcare environment, what's really going to happen and what are the barriers. It's not just technology. Technology is hard to get right, but even if you get the technology right, you still have the human problem of how do you manage all that risk? Do you really want to deploy a patch on 50,000 infusion pumps simultaneously in a hospital? What happens if something goes wrong? What if something unanticipated happened from interacting components that's not regulated by FDA, because
Mm.
FDA regulates individual device models, not the entire ecosystem. So there's a lot of unpredictable behavior that can happen. And that's why a simulator can go a really long way at really understanding how to de-risk this, and to understand the problem, and make it more possible to patch things so that the devices will be cyber secure for healthcare delivery.
That's amazing. And you know what? It highlights to me even that it's not just then a way to know how you're responding on, say, the IT side or the health IT side, but also what considerations hospital leadership should be taking, even on a resourcing side, right? If you simulate something, you go, well, who's in the know? Is part of the need to know program? Who is supposed to be part of the, I guess, the risk response team? Anything like that? Are those also considerations?
So we have, well, an infinite list of different features,
Yeah.
and so maybe the question would be, well, what's the MVP? What's the minimal viable product of what do you have to have in
It's a
there?
different MVP than I thought. Yeah.
Yeah, different MVP. Yeah, go Red Sox. But the but I think key to this is having a notion of representing human behavior
Yeah.
in the hospital environment. And that's why working with clinicians, so Archimedes does this on a daily basis. That's why we work with AAMI, because
Mhm.
of the rich community that AAMI has built. But making sure that any technology that is created is not created in some magic laboratory sterile environment that's absent of any human um, behavior. Remember, to err is human, and so things, mistakes will happen, and that's normal. And so the question is, how do you design your technology to work in that messy space?
Yeah.
And I think most technologists don't have the opportunity to even work in a hospital to see how things really work, and you're not going to find this in a book, right?
That's fair.
This is why the practice of medicine is one of the oldest apprenticeship based professions.
Oh, I mean, it's exciting stuff. I'm really looking forward to sharing more news about what's coming out of the patch program as it progresses. But in the meantime, thank you for dropping by. It was a really fascinating panel. We're going to have a write up in about it in AAMI News, so people can look forward to that as well. And enjoy the rest of the conference.
All right, thanks for having me.
Thanks.